For questions, we will be using the Q&A box to ask questions, and for general chat, you can use the chat box. Or if you prefer, you can unmute yourself at the end of the session and ask your question in person. I would just ask that you raise your hand if you do so. This webinar has been approved for 1.5 hours of RACE CE, and those certificates will be sent out after the webinar. The webinar will be recorded, which Talia just started for us. And a link will be shared after. So if anyone who couldn't make the live presentation, they will be able to access the link later on. However, at the moment, RACE CE certification is only available for those who attended live. And if there's any questions related to the course itself or IT concerns, please email kaz@animalhealth.ca. So with that, before I begin, I would like to respectfully acknowledge that the land that we work on, the land that we farm, and the land that we keep our horses on is the traditional unceded territory of the Maliseet, which is covered by the treaties of peace and friendship. So with that, I'd just like to do a very quick introduction of CAS for those who are unfamiliar. The Canadian Animal Health Surveillance System is a division that supports the surveillance pillars of Animal Health Canada. CAS has been active since 2019. We are an independent, member-driven network of networks with broad-based support from industry, governments, and other One Health partners. We strive for effective, responsive, and integrated animal health in Canada. We currently have 7 species groups, including equine, and 2 special topics groups, which are AMU, AMR, and vector-borne diseases. We meet regularly every 3 months to share information relevant to animal and One Health and surveillance. If you're interested in joining any of the networks, you can do so at the website, kaz.ca. For some of the equine tools and resources from the equine network, they've generated some infographics targeted at horse owners based on conversations and surveillance needs identified by the surveillance network. There's also a surveillance stakeholder map, and what may be of more interest with the Strangles talk that we're going to have today is the disease alerts and the equine disease alert dashboard. So within the equine page at the CAS website, you can access the disease alert dashboard, which allows you to filter disease outbreaks and results by year, by date, by agent organism, by province, and get the dashboard, the map, and the different graphics to sort of show you what's been going on and what the trends have been over time. You can also access a reportable disease table, which will let you know which diseases are federally and provincially reportable, which ones are immediately notifiable, and which ones aren't. And you can subscribe to the disease alert system for various networks, which will send out disease alerts as they come into CAS that may be relevant to your area. You can fill in these disease alerts too yourself if you diagnose, for example, Strangles. You can go to the CAS website and submit a disease alert to us to let the network and all the networks know what is going on. And so with that introduction out of the way, I'd like to turn it over to our great colleague and collaborator, Dr. Barb Wilhelm, for a few words on WECAN.
Well, thank you, Murray. No pressure. I feel that that's very kind of you. Yeah, anyway, so welcome all of you. The Western Canadian Animal Health Network, or WECAN, is also an animal health surveillance system and a regional one structured very similar to the Ontario Animal Health Network and Réseau in Quebec. And so we're organized in a series of species or sector-specific networks, also like CAS. And so ours all work the same way. Every 3 months, a fairly small group of people get together from a variety of backgrounds. So we have veterinary practitioners from across the West, diagnostic lab reps from each of the 4 provincial diagnostic labs, researchers, provincial veterinarians, some vet college faculty. And we all get together to share what information we have on animal health diagnoses and issues in that sector over the past 3 months. And so everyone contributes what they can, but the biggest data sources for all of the networks are, first of all, the surveys that the veterinary practitioners who are participating complete, and also the data that's downloaded from the 4 provincial veterinary diagnostic labs. And so we get together, we discuss this data set. The information that's discussed at the meeting is approved to be shared publicly, and then informs both for animal owners and veterinary practitioners. And so Marianne and I are currently pulling together equine data from the 4 Western Labs lab information management systems as we get ready to launching Weekend's new equine network later this spring. So I'll maybe be able to talk to you very briefly about some of the Strangles data in a little bit. But thanks, Marie, for that.
Thanks, Barb. And that brings me to the introduction to our speaker today. So it gives me great pleasure to welcome and introduce Dr. Ashley Boyle. She's board certified internal medicinist and an associate professor of medicine section of the field service at the New Bolton Center at the University of Pennsylvania. And her research focuses on Streptococcus equi and Strangles. So with that, welcome, Dr. Boyle.
Thank you. Just getting it to slideshow. There we go. Okay. And okay, well, thank you very much for being here tonight, and it's a pleasure to be here. And I'm going to get started on talking about Streptococcus equi. It's a gram-positive aerobic cocci found in long chains. Transmission is by inhalation and by direct contact. The bacterium attaches to the crypts and the epithelium of the lingual and palatine tonsils, and clinical signs can develop in 3 to 14 days after exposure, but may actually take even a little bit longer than that. Shedding can start 48 hours after onset, and that'll be actually very helpful in management of outbreaks. And this can typically persist for a minimum of 2 to 3 weeks, but recovering horses often shed for as long as 6 weeks, if not longer. And then we all know that carriers in the guttural pouch can shed for potentially years. So the immunity can, the textbooks talk about it being a 5-year immunity, but that's a waning immunity. So obviously that, and it depends on whether they've been treated with antibiotics or not, whether they are, how much immunity that they develop. Foals from infected mares are often protected by maternal antibodies. So first signs can be acute onset fever, often greater than 103 degrees Fahrenheit. And this will be associated with lethargy, depression, and bilateral mucopurulent nasal discharge, and submandibular and retropharyngeal lymph nodes. But they can also have other unusual locations, such as this horse who has ocular discharge, and that ocular discharge was positive for strep equi. Other areas would be the parotid region and the prescapular region. Some horses will actually present with respiratory stridor or dysphagia, inability to swallow, and neck extension as seen in this weanling here. But some will also present looking very normal. So this horse on the left was positive for strep equi, just had a small amount of nasal discharge out of both nostrils. This horse was in the same outbreak as the weanling on the screen before, and the horse on the right could very easily be a carrier, an asymptomatic carrier. So moving on to diagnostics, bacterial culture historically has been one of the go-tos to make your diagnosis. And the important thing is to take your sample from the area that you're seeing the disease. So if you're actually seeing a submandibular abscess, that's going to be a gold mine for your sampling. But you can also do nasopharyngeal swabs. I actually prefer nasopharyngeal washes and guttural pouch washes. But you don't want to take a guttural pouch wash if the horse is at the very beginning of the disease, because it's probably not going to actually be positive. Preliminary chain reaction is, or PCR, is your DNA amplification. It's much faster than culture, and especially if you're able to get it to the lab right away. Even if you are getting it to the lab the next day, that often can be faster than culture results. And you can do the same samples with that. So these are some good pictures of horses with submandibular abscesses and retropharyngeal abscesses. And so, as I mentioned, this is a gold mine for sampling. So if they're mature enough, you can aspirate them and take your sample from there. Here we're taking a nasopharyngeal wash. So I actually use all the things that I already have on my truck. So rectal sleeve, it doesn't need to be a sterile rectal sleeve, a uterine pipette, and a 60 cc syringe. And I advance the uterine pipette through the outside of the rectal sleeve and then pass it up the nasal passage. And at the same time, just quickly put the bag over the nose and infuse the saline and collect it in a finger. And then guttural pouch endoscopies can be very useful for horses that are having repeated nasal discharge for an extended period of time. These horses might actually have empyema, and you may want to examine their guttural pouch. So what is considered the diagnostic gold standard? So the sensitivity of the test really depends on, as I mentioned before, the stage of the disease. So if it's early on, you may actually not get a positive sample, because if it's within that first 48 hours, they may not be shedding yet. The site of sample collection, so whether you're doing it from the nasopharynx or the guttural pouch or the submandibular lymph nodes or retropharyngeal lymph nodes, and then your method of sampling versus PCR versus culture. And then there are different labs use different target genes for their PCR. And then there are also other ways to do amplification methods that are not all commercially available, but there's things called loop amplification as well as PCR for DNA amplification. So culture is no longer considered the true gold standard, because it can miss about 40% of positives because it's not as sensitive. And historically, in the first consensus statement in 2005, Sweeney et al. Talked about needing 3 nasopharyngeal washes. And why is that? So 1 culture and 1 PCR combination only had about a sensitivity of 53% with a specificity of 71%. So by doing 3 consecutive nasopharyngeal swabs, or maybe preferably washes at this point, would be bring that sensitivity up to 93%. No one has actually done the comparing 3 guttural pouch washes, but if you're at the end of an outbreak, I feel very comfortable looking at a guttural pouch once and looking at it with an endoscope and seeing that they are negative with a negative PCR. So a group out of Sweden compared different samples at the start of the outbreak, and they looked at the rostral nasal passage, so just taking a short swab, taking a nasopharyngeal swab and doing nasopharyngeal washes. And they found that the nasopharyngeal lavage, or the wash, was more sensitive than either swab. The PCR was more sensitive than the culture, and they also found that taking 2 sample sites at the same time was better. So this was in the beginning of outbreaks, within the first 10 days. We then looked at the comparison of nasopharyngeal samples to guttural pouch samples to determine what is the best place to detect carriers. So these are the horses that are at the end of the outbreak and trying to figure out where the best place to find the carriers were. So we took client-owned animals recovering from naturally occurring disease, and we sampled using a nasopharyngeal swab, a nasopharyngeal wash, and a guttural pouch lavage in that order. And we took the guttural pouch lavage directly from the guttural pouch at that time, not from the nose. And we did find that the guttural pouch was actually 50 times more sensitive than the nasopharynx in our study. And we felt that that provided evidence to eliminate the need for repeat testing with nasopharyngeal washes or swabs, potentially saving time and money. And we had a really poor performance with nasopharyngeal swabs. So again, the group in Sweden also did a similar thing, and they actually looked at samples. They actually found some samples that were positive in the nasopharynx and not in the guttural pouch. So in conjunction, we've now recommend that we take samples from both areas simultaneously. So if you're doing a nasopharyngeal, or if you're doing a guttural pouch lavage, you can take the sample from the nose, and so you're sampling both the guttural pouch and the nasopharynx. They also found that horses that were PCR positive and then culture negative at the same time were actually found to be culture positive 8 months later, which is actually quite disturbing. And then Dr. Cohen's group, they were actually looking at whole genome sequencing, and they actually, as a kind of a side note in their study, they actually were using horses. They had horses that were positive for strangles, obviously, and they used repeated culture negatives to determine whether the horses could go back into an outbreak. And they did not use PCR at that time, PCR to determine that. And they actually, despite having repeated culture negatives in these horses, they actually started another outbreak when they put the horses back in the rest of the research herd. And they actually showed that it was the same genomic sequence as the previous outbreak. So they knew that it wasn't like another outbreak. So this does strengthen the need for looking at PCR. So how do we determine whether a horse is not a carrier? So in the absence of obvious guttural pouch pathology in conjunction with a negative guttural pouch nasopharyngeal lavage PCR results is what I like to use for determining that a horse is not a carrier. So I like to look into the pouches at the same time as getting the PCR. John Pringle's group in Sweden also looked at nasopharyngeal washes. They did show that 3 nasopharyngeal washes were able to predict the carrier status when they compared to guttural pouches. Now, one caveat to this is that the guttural pouch endoscopy was done not at the exact same time as the nasopharyngeal washes. So it's possible that and more time had passed when they did the guttural pouch endoscopy. So it's possible that things could have changed from when they did their washes to when they did their lavages of the gut pouch. Another study actually out of Canada was that looked at the cycle threshold count. So the cycle threshold count, when you're looking at PCR, is the higher the number, the less bacteria is present. And usually a lot of labs use a cutoff of 40 to say if it takes 40 cycles to try to find the bacteria, then it's considered negative. And so Scott Weiss and his group looked at what was the value that could actually be culturable strep equi, what cycle threshold value, and they found that a value of 34.2 was a reasonable break point and could potentially be used to determine in risk assessments as to whether you're dealing with culturable strep equi. This breakpoint will depend on the lab. In our lab at New Bolton Center, that number was closer to 36, so it was a higher cycle threshold number. Another thing that we've done is looked at using permimidine monazide, which actually, when you treat a sample with the PMA prior to PCR, you can actually determine and which strep equi is viable. So you would only amplify the viable strep equi. The one caveat to this is not commercially available, and samples do need to be fresh because they will die in storage. And you could get basically false negatives, and things can also die in transport, but it might be a way to determine whether you're dealing with an infectious horse. So moving on to treatment, goals of treatment for strep equi will be to control the infection, to eliminate disease, and to try to provide lasting immunity. And in simple cases, you can provide supportive care, isolate them, and have maturation and lancing of external abscesses as pictured on the right. The use of antibiotics really should be for the treatment of animal welfare. So in the consensus statement in 2018, we actually discouraged the use of antibiotics as a preventative. It gives a false sense of protection. It also might lead to resistance. There are chondroids that have had bacteria that have developed 4 times the MIC to penicillin. And then it's important to use the correct dose and frequency. And penicillin is definitely the drug of choice. It works very well for strep equi. Obviously, it can be challenging at times to actually get this into some horses. And I know that a lot of people have started using ceftiofur, but you could argue that that is kind of too big of a gun and not, maybe not so great for antibiotic stewardship. But I've definitely had to use it myself, so I don't want to sound like I'm preaching from a tower here. So potential scenarios to use antibiotics would be of fever prior to lymphadenopathy. Very often we don't get the opportunity to do that because they have already developed lymphadenopathy. If they do have lymphadenopathy, the animals that probably should get antibiotics are the ones that are quite sick and not responding to nonsteroidals, and they're having trouble eating. They're having persistent, really high fevers of like 105 for days on end, and you're worried about their hydration status because they're just not feeling well. Other scenarios would be in metastatic strangles, such as otherwise known as bastard strangles, as well as and with purpura hemorrhagica with concurrent use of corticosteroids. And then I am a proponent of local treatment of guttural pouches with antibiotics. If you're going in there and you need to lavage them out, I think it's beneficial to treat the guttural pouches. So guttural pouches may or may not have empyema. They may or may not have chondroids. I find that the chondroids happen when things are much more long-standing, and you may find a horse that is positive for PCR or a plus or minus culture with your empyema and chondroids. So ways to treat these animals is to physically lavage the guttural pouch. You can do that with a Chambers catheter, via the endoscope, indwelling catheters. Often the indwelling catheters are hard to keep in if you're trying to keep them in for a couple of days. I've had luck with acetylcysteine and often leaving the acetylcysteine in for a couple of days and leaving the horse alone for a little while and then coming back and seeing how well it's worked. But a lot of it is also just manual removal with the endoscopy equipment, which is being shown here with a memory helical polyp retrieval basket. I'll use the basket even just to remove the debris, not always just for chondroids. And then once you've cleared it and gotten rid of all the empyema, local and sometimes systemic penicillin therapy is needed and to help prevent against aspiration in the process of doing all this lavaging. So these are, this is a horse that I actually used a embryo transfer Foley catheter. We have ones that are, our repro department doesn't reuse them. They always use a new one. So they have extras around that I often put in Strangles horses, and it's sticks out for a lot further than the typical straight Foleys. And then on the right, there's just a picture of the Mila, a diagram of the Mila guttural pouch catheter, and it shows the coil that is helps keep it in the guttural pouch. But very often horses will get any of these Foley catheters and Mila catheters out. So they can be frustrating. Metastatic abscessation is otherwise known as bastard strangles, is when they're spread to mesenteric and cranial mediastinal lymph nodes, sometimes to the liver, to spleen and kidneys. There are reports of this happening in up to 20% of cases with external abscessation. We did a retrospective of 108 cases of strangles, and we didn't have any bastard strangles in that retrospective. So I think it kind of depends on strains that you're dealing with and how severely affected the animals are, and how well things are isolated to help prevent the spread of disease. These horses can often present as a fever of unknown origin for months after the original outbreak. They will present with anemia, with so often you can palpate a rectal mass on palpation per rectum. You can sometimes find things on ultrasound, and they may actually have a peritonitis that when when you do abdonocentesis, you can culture strep equi if the abscess has ruptured, and they'll often present with chronic colic signs. Nicola Postella did a paper a while ago about the need for these horses needing a mean of 2 months of systemic antibiotics, and they will have high SEM titers, which we'll talk about in a minute. Purpura hemorrhagica is an aseptic necrotizing vasculitis, and there are immune complexes in the blood vessel walls. Often occurs in mature horses after repeated natural exposure to infection. Can happen after vaccination of horses that have had strangles. And John Timoney had unpublished work where the horses that had SEM titers greater than or equal to 1 to 3,200 were at higher risk of developing purpura at the time of vaccination. So these horses with purpura will have pitting edema, petechia and ecchymoses. They can go into organ failure. Diagnostics will include abnormal coagulation profiles. They'll have abnormal skin biopsies, and they may or may not have high SEM titers. And treatment would include supportive therapy, corticosteroids, and systemic antibiotics, as I mentioned. So moving on to serology, there's actually 3 different serology tests available. The most common one in North America is the whole SEM antibody titer. And then there's the combined antigen A and antigen C titer. And then there's a third one that has been reported out of Japan. And these are all targeting antiphagocytic surface proteins on the bacteria. So the SEM antibody titer, an example is if you're in the US, IDEX and Equine Diagnostic Solutions, this is the antibody titer that they run. IDAVET is in France, and there can be some cross-reactivity with strep zooepidemicus. So it's not quite as sensitive or specific as we may like it to be. And titers can take a number of weeks to develop. So a high titer is considered greater than 1 to 3,200. Davidson et al. Showed that there was no correlation between serology and carrier status. We looked at identifying risk factors for having a titer greater than or equal to 1 to 1,600 in healthy horses. And we found that older horses had titers, non-thoroughbreds and non-thoroughbreds and warm bloods non-thoroughbreds and non-warm bloods were more likely to have higher titers, and horses that were previously vaccinated with Pinnacle intranasal vaccine. And we also inadvertently showed that it was safe to vaccinate with a titer of 1 to 1,600 because people wanted to continue to vaccinate their horses, and we were running the samples later on. So then we looked at risk factors for titers greater than 1 to 3,200, and the biggest factor was the history of clinical disease. What was protective was, interestingly, farms with larger numbers of horses, if the horse was a stallion, and then time. So with each year, there was less likely to have a high titer. Based on this, we recommend evaluating SEM titers within 1 year of clinical disease, and before vaccinating. And we also showed that there was a trend for antibiotic use to lower these titers. So these horses may not be mounting as good of an immune response. Delph et al. Out of Kansas looked at horses after an outbreak that 33% had titers greater than or equal to 12,800, which is quite high, 8 weeks after infection. And only 12.5% of those actually had complications. So just because they have a really high titer does not necessarily mean that they have bastard strangles or purpura if they're doing fine clinically. So some take-home messages about the SEM titer is that it's not a measure of active infection or carrier status. And that's really important to drive home that, you know, I don't use that test in the face of an outbreak when I'm trying to diagnose horses. And we don't want to vaccinate if the titer is greater than or equal to 1 to 3,200. And we recommend testing older horses that have had a history of clinical disease within 1 year. Or if you have no medical history, then that may be another good time to actually test them before you vaccinate. Do I always get to do that? No, but that's what I recommend. And then it can assist with diagnosis of metastatic abscessation and purpura hemorrhagica, but serologic values are not necessarily a measure of protection. So the combined SEQ 2190 or A and the SEM is available in the UK and some other European labs, and it's claimed to have a higher sensitivity and specificity, and maybe could be used as a screening tool for asymptomatic persistent carriers. But then there's been a recent paper that looked at carriers on in guttural pouches with endoscopy and using PCR, and only one of these 9 horses was positive on this combined antigen A and C serology. So the jury is still kind of out on whether this should be used as a measure of carrier status and so forth. The other thing that we looked at is that with the combined antigens A and C titers, you actually most vaccines will actually interfere with this test. So we looked at horses that had pinnacle vaccination from and 14% of the horses were initially positive, and then 5 weeks post-vaccination, they were 72% of the vaccinated horses had seroconverted. So in a mixed population, 37% of the population vaccinated and non-vaccinated were actually positive on this titer. And we did not have the opportunity to scope them, but they were actually all outwardly healthy horses, and no outbreaks occurred while we were doing this. So moving on to methods of outbreak control, the consensus statement, we talk about using red, amber, green categorizations. The red being the infected horses, amber being the exposed and contacts, and green, no disease. And then I also like to have a group of horses that have been tested, that have been scoped, and I don't necessarily put them back in with the green group, because you never know who might be the carrier and the inciting cause of all of this. So I sometimes try to keep those horses that I've cleared separate, because there has been some susceptibility post-antibiotic treatment seen. So we want to isolate the horses with fever, temperatures taken of all the other horses twice a day, if at all possible. I know that's much harder to implement than it is to just talk about. But that goes back to the fact that the horses won't shed for 48 hours. And if we can catch them earlier and move them, then we're going to slow the progression of the outbreak down. And using barrier precautions and separate cleaning equipment. So I like to, this is kind of like a schematic that I like to use. So you have a horse with clinical signs, you isolate them to the dirty or red areas, put the in contacts in another area that would be your amber area. So this is the traffic light system, and then monitoring temperatures and supportive care and taking temperatures. And then you're going to move untested horses to a recovery area, start testing 2 to 3 weeks when there's been no clinical signs for 2 to 3 weeks. One caveat for that is if the clinical signs last longer than 2 weeks, I would highly recommend performing an endoscopy exam, because those I've been gotten myself in trouble by waiting longer, and then if I had scoped them earlier, I might have actually been able to clear the outbreak faster by actually manually removing the empyema that might be in those horses. So if they're positive, treat and lavage as necessary, and then move them to an recovery area that with negative horses, and then and I like to use the guttural pouch lavage and endoscopy to determine that they are free of disease, if at all possible. One of the key things for cleaning and disinfecting is actually also making sure that things have an opportunity to dry. A lot of disinfectants actually will kill strep equi. Obviously, bleach doesn't work very well when the bleach is dirty, which is hard to keep clean when you have foot baths and so forth. Ryden et al. Out of Sweden looked at the effectiveness of cleaning equipment that they had purposely contaminated with strep equi, and they actually found that leather was actually much easier to clean and much harder to isolate the bacteria after they had cleaned it, versus, for example, a nylon halter. It actually had to go through a really high temperature wash machine of 60 degrees Celsius versus 40 degrees Celsius. They were still able to recover strep equi off of those nylon halters. So maybe destruction of some of the equipment would be useful. I often recommend resting pastures for 2 to 4 weeks. In the laboratory, it was in laboratory conditions, it lasted for 48 to 63 days. In Scott Weiss's project, in field laboratory conditions, they were only able to culture it for 4 days. But then Durham et al. Looked at different instruments and different ambient temperatures in the winter versus the summer months, and it actually stayed in a wet nasogastric tube for 35 days. So we need to be careful about how we clean our equipment. Speaking of equipment, we also need to be careful how we clean our endoscopes. So this was a study that looked at using accelerated hydrogen peroxide versus OPA for cleaning the scopes. And this was actually them contaminating the scope with strep equi, so it probably had a higher contamination load than what would be when you're going into your horses. But they found that the accelerated hydrogen peroxide was actually more effective than OPA, which is usually the more standard product that endoscopes are cleaned with. So for prevention, we want to isolate new horses for 3 weeks. And this picture is a horse that the client actually was keeping her new horse separate in her backyard, separate from her barn, destroying her nice lawn. And then some people have even gone to the trouble of doing guttal pouch washes, screenings prior to bringing them into the barn. That's obviously very labor intensive and costly. And then vaccination can be useful for prevention. So we have the intramuscular strep vax 2, that's by Boehringer Ingelheim, and then the Pinnacle intranasal by Zoetis. And some of the advantages of the Pinnacle product is that there is mucosal protection, but for both of them, I would not recommend vaccinating if the SEM titer is greater than or equal to 1 to 3,200. Remember that your Pinnacle vaccine is a modified live bacterial vaccine, so you want to wear gloves and ideally not do any other procedures or vaccines on the same day. So is it appropriate to vaccinate during an outbreak? And this is considered controversial, and some people will say, well, they'll try to choose the right horses and use the right management to prevent purpura by only vaccinating the horses that have not been exposed. And there was a paper in Equine Veterinary Education by Chrisman and Pink in 2017 that actually they tried to do that, and they still ended up with 4 horses that came down with severe cases of purpura that had been vaccinated. They had 6 total in the outbreak of, and this was like a 1,700 horse farm, but so ideally I would not recommend vaccinating in the face of an outbreak because of the risk of purpura. The other problem is that there's no ability to test these horses for disease until many weeks later. So it's been shown that horses that are vaccinated, especially with the modified live vaccine, will be positive on PCR for up to 60 days. So again, I would recommend testing with SEM titers if you're thinking about vaccinating within 1 year of an outbreak. And there are also some papers that have looked at, is it appropriate to vaccinate horses that are less than 1 year? There have been some cases of Strangles-like disease that have come from the vaccine in the young horses, and the Borst et al. Paper actually found abscesses on postmortem on these ponies that were less than 1 year of age that were vaccinated with Pinnacle. There is one new vaccine out there that is approved in the EU and the UK, and it's a multi-component chimeric fusion protein vaccine. It's supposed to provide 94% protection after an initial series of 3 vaccines, and it has the ability to separate on serology, so you can differentiate horses that were infected from natural disease from vaccinated animals when you're testing with serology. So that may be helpful. And I know that they're trying to potentially get it into North America, but it hasn't come here yet. So in conclusion, some things so you don't want to forget about atypical presentations of strangles. They don't all present with the classic submandibular lymph nodes or retropharyngeal lymph nodes. Sometimes they can look quite normal. The diagnostic sample depends on the presentation that you're seeing. PCR is more sensitive than culture, but sometimes that can be troublesome because you're not sure whether that PCR positive culture negative horse is going to be contagious or not. But some horses have been shown to transmit disease that fall into that category. And then doing guttal pouch does look like it's the best for looking for carriers, but a combined nasal pharyngeal and guttal pouch lavage would catch even more. And that is everything that I have.
Okay, thank you very much, Dr. Boyle. Very interesting stuff. Boy, strangle seems a lot more complicated than when I learned it in vet school. So we're going to hold the questions just to the very end. But just as a reminder to participants, again, you can place your questions. Please use the Q&A function for questions. It should be at the bottom of your screen. However, if you have an updated version of Zoom, they may have moved it to the 3 dots. So if you're looking for the Q&A tab and it's not at the bottom of the screen, you may want to check the 3-dot option, the more option at the bottom. So with that, we're going to move into the cross-country update. So we're very pleased to have representatives from all the different areas of across Canada to give very brief updates, current situational updates about what is going on with strangles across the different networks and across the different regions. And as they are talking, I will put their bios in the chat just for people who are interested. And I was going to say, I was going to start with where it's latest, which would be here in Atlantic, Canada, where I am. But I think Kathleen is in Toronto, so maybe it's not as late. But I think we will start with the Atlantic region. So I will call on Dr. Kathleen McMillan to provide her update.
Thank you. I'm actually in Ottawa, but I'm not in the Maritimes today. So I'm happy to report that things have been quiet of late in the strangles front. There's no recent cases in PEI that I'm aware of, and I double-checked that with the lab today. New Brunswick had a case on February 19th, and there was another one last fall that they've reported. And then in Nova Scotia, they had a few cases late last summer, fall. But as far as I'm aware, that has been quiet as of late as well. Something I think that's important to know is that strangles is not notifiable in the Maritimes. The PEI government, we had a working group back in 2019 before COVID hit, and there is a desire to make that notifiable within the equine groups. So that's something that the provincial government is working on and would like to have that passed through the legislature before it can become a regulation. So that potentially may be coming in the future. And my understanding is that New Brunswick is also on board with that as well. So I'm happy to report that right now things are fairly quiet, knock on wood.
Okay, thanks, Kathleen. And again, a reminder, if you have questions for the panelists too, for the different regions, you can also put them in the Q&A chat. So we will continue to move westward, and I'll invite Martin Rondeau to provide his update. I think I saw Martin join. Oh,
Okay, I found it. Okay, here in Quebec, we have a coordination with provincial labs. Here, we have a good collaboration. Strangle is not notifiable disease. Then, if I don't ask them to get these infos, I wouldn't. But fortunately, I got a good collaboration with the two major labs we have here, BioVet and the CDV-UM, and they give me all the positive results of all PCR they are doing on each 3 months. So 4 times a year, I have these infos, and for the year 2023, we got 17 strangle PCR positive tests. Then we don't know, we have the information about the region, where are the cases, but we don't have personal information. They are denominalized information, but we have the info of the veterinarian region where they've done the test, because I don't have the information of the owners, but it's quite good. It's better than nothing, and I'm very glad to get this information from these two labs, and they permit us to have an idea of what is testing, and we don't have the negative results, but we have the positive results. So it gives us an idea of the number of cases we have. But I think that only Ontario has a notifiable disease for strangle in Canada. Do you have some questions or more information you want to know?
Not right now, Martin. That was great. Merci beaucoup. If there are questions for you, I'll ask them at the end, but thank you very much. And your talk will segue very nicely with Ontario and the reportable disease into our next speaker, Dr. Allison Moore. Allison, do you want to share your slides? Or do you want me to pull up your slides?
You please, if that's okay.
Okay. And while I'm doing that, I'll apologize. The bios are copy and pasted from the document, which the spelling's right, but when I pasted it in, it's not pasting it all properly. It was Martin Rondeau. It's not Martin Rondeau, but I don't know why it's doing that. That's really weird. All right, so I'll pull this up and I'll just oops.
So as Dr. Rondeau mentioned, Strangles is immediately notifiable, and it is not quiet like in other places, unfortunately. So I just put some slides together. It's in, yeah, there we go. So S. equi, so we go on the pathogen. It became immediately notifiable under the Animal Health Act on February 1st of last year. So prior to last year, we received annual testing results, but we didn't have any context for them. So we couldn't do a whole lot with that information. And one of the things that comes out, because it's notifiable, there's a lot more people talking about it, and we report strangles cases. So horses that are clinically affected with strangles are reported to the EDCC. So there is a lot more conversation around it. So I decided just to look in comparison to 2022 in terms of, are we seeing more? So in 2022, we had 2,974 positive S. equi tests, or sorry, S. equi tests performed, and 174 were positive. So that's a 5.8% positivity rate. And then last year, 3,313 tests were performed and 210 were positive, so 6.3%. I don't think they're statistically different. The context might be different, but the overall positivity isn't really different. Next slide, please. So what I also wanted to show was since 2019, the percentage of positive tests from the one lab that we received by quarter. Typically, or in previous years, and there was an article that came out very recently too, looking at the seasonal change in the occurrence of strangles. And I would have said, yeah, I think we see more in this spring, winter to spring, and the fall to winter changes. But certainly last year, they were very evenly spread throughout the year. Maybe a slight dip in the summertime overall over the last 5 years, but pretty even. Although I do find it interesting. So the study that was out of the States by Thomas et al. So they were looking at trends in temperatures and precipitation data. They found that it was the changes in temperatures that precipitated the onset of strangles outbreaks. And I think that makes a lot of sense to what we see in Ontario when we have weird weather and we have such dramatic changes. It does seem to precipitate an onset. Can't say that with a whole lot of evidence yet, but it does seem to act a bit like herpes, where when we get weird weather, we'll get outbreaks. And we've had farms where there have been no changes in terms of horse populations. All of a sudden, they have a strangles case. And I imagine they've had carriers on that farm or a carrier, and whatever stress related to weather has precipitated them shedding more, although that's purely speculative on my part, but seems to make some sense. Next slide, please. So this was just some data that I put together, just descriptive of what we saw last year. So last year we had 27 facilities that were affected by strangles. So again, these are clinical cases. Of the 27 facilities, 16 were boarding and riding lesson facilities. 7 were private farms. 5 represented farms where horses were used as the primary source of transportation. 2 facilities were broodmare operations, and 1 was a training facility, meaning it wasn't a public facility. It was used for high-end performance. Of the 27 facilities, and I thought this was encouraging, 25 were able to isolate infected horses either at a separate farm with no horses, in a separate barn at the facility, at one end of a barn, or an outside paddock. So they were able to isolate. And I think the separate farms, which is kind of a sad state, there's a lot more empty barns around, does present an opportunity for some people to relocate some of those infected horses and use them as an isolation facility. Of the 27 facilities with strangles, 6 facilities had a history of chronic nasal discharge in the herd prior to the strangles diagnosis. And this goes to what we've seen over the years, and as Dr. Boyle mentioned, that nasal discharge may be your only sign. And I think that's one of the most common signs in the UK with their strangles outbreaks as well. 5 of the facilities bought horses from dealers, which shouldn't really be a surprise. 3 facilities had staff associated with rescues, meaning that they worked at other rescue facilities. And 3 facilities had shared water sources between paddocks. So I think this kind of information is they're good speaking points to talk to clients around some risk factors related to strangles. Now, they're not strong numbers yet, but at least they're discussion points. Where we have a bit of challenge are the number of horses that are being screened to move between facilities. So a lot of our boarding stables are requesting strep equi testing prior to a horse comes on their property. And we had 24 horses that were positive for strep equi. And they're a challenge for a lot of our vets to know what to do with them. So the way they've been handling them is to repeat the testing the following week if the owner is amenable to doing a guttural pouch wash. Most of them come back negative the next week, which speaks to sort of a transient exposure or infection in these horses. But it also speaks to the fact there's likely a carrier on the farm, and then it creates a little bit of problem because those results belong to the owner, not the farm manager. And that's where the vet-client relationship is, with the owner of the horse, not the farm manager. So in some passing conversations, we've had some discussions, maybe farm managers need to have some contractor discussion in place with clients on releasing information related to infectious disease as one potential solution. Next slide, please. I just wanted to bring this slide up because it's relatively new. It's a disease surveillance portal that we have on the Ontario Animal Health Network website, which is oahn.ca. Under the equine network, there's a equine disease alert tab, and at the top of it is this portal. So it shows where, again, the strangles facilities are. And if you click on the counties, it'll give you the dates of diagnosis. So kind of gives you a timeline. Next slide, please. This is the last one. Just wanted to mention where we report. So again, we're reporting clinical cases to the EDCC. So we've encouraged veterinarians to sign up, and owners are signing up as well to follow that. And CAS will pick them up from the EDCC as well. And then again, we have some resources available on the Ontario Animal Health Network for Strangles in particular. There's a dedicated Strangles resource page. And that's it for me.
Thank you, Allison. Stop sharing. So we'll move further west with our next panelist, Dr. Ashley Whitehead.
All right, I'm going to share my screen here. I'm sorry, it's just wanting to be an annoyance. So I'm going to add to some of those lovely pictures that we've been seeing today. We in Alberta, so I'm at the University of Calgary and work in private practice out here through a distributed program and consult with many of the veterinarians. Strangles is a daily occurrence pretty much for our veterinarians in Alberta. We have a very active cases, and being that it is not in any way notifiable or reportable, that data ends up going into the never land. That's a little bit more hindered, or a lot hindered, by the fact that at the moment, our provincial laboratory at the university, the Diagnostic Services Center, the Diagnostic Services Unit, does not have molecular capabilities. That we should be in the next year having those. But right now, the only diagnostic that we would have that immediate data on is culture. So we are seeing lots of our kind of traditional strangles out there, a lot of descriptions coming from clients that their horse was at a trainer's, they were at the show, they were at the jackpot, some snotty noses. What we are seeing quite a bit of as well, though, is we are seeing quite a lot of complicated cases. And so we do quite a number, flushes, surgeries for guttural pouch empyema and chondroids, I had to include this one picture here because this horse, we actually were able to use a large nasogastric tube in the guttural pouch. This horse had multiple surgeries and a very resistant case. That metastatic strangle is also very common. The horse on the left here is one that I saw this year. And it looked very much like that pigeon fever type of thing, although we have had it in Alberta. It's extremely rare to get it here. But getting those metastatic ones, that's a picture from a belly tap, also on that same horse, with just a raging peritonitis as we went along. So because I don't have any molecular data to share with you, I did work with our bacteriologist at the Diagnostic Services Unit and pulled out our current bank from the last few years since we've been doing our antibiotic sensitivities. We are using the MALDI-TOF and Biotyper as well as the Sensititer with the veterinary system there for it. And what this is our typical response. We're not seeing many changes within the bacteria that we are culturing. They pretty much every single one of them has resistance to our amikacin, gentamicin, as is known within our strep equi. And all of the the colonies that we have done were also resistant to enrofloxacin. There was some variances within the numbers of the MIC for the enrofloxacin and gentamicin, but not too different, just slightly in there. I was at first worried because we are seeing so much of the kind of the more clinical cases, the metastatic, that we were going to see changes in some of this, but it's definitely not yet at the sensitivity level for our antibiotics, which is a good thing. Obviously, penicillin, as was discussed, is going to be our mainstay if we are going to be going for those treatments. And I just wanted to kind of do a couple things because we're getting more into using our MICs, which I think is fabulous. And then you have to obviously have some kind of concept of where they're coming from and why we have them. And this goes a little bit towards when we're discussing like using trimethoprim sulfa and some of the other antibiotics in our treatments if we have a horse that's not penicillin friendly for those major injections. So our units, our antibiotics on the side here with the horse are ones where we have the cutoff value in the CLSI, which is the Clinical Laboratory Standards Institute for horses. So those are our antibiotics in which our concentration range for the MICs are based off of the Streptococcus equi or Streptococcus species for them, versus our other antibiotics are using human cutoff points, and that includes the trimethoprim sulfa on there. However, there was recently in 2016 a study that did start to look at some of those cutoff points in horses. It's just not included in the CLSI as of yet, to my knowledge, on those. So we're getting some good culture results. I don't think I've ever had one negative yet. And this was something that I was actually going to put in the questions because we were discussing how that gold standard. We've been lucky in that our results here at the DSU, we usually get our cultures now, our preliminary results faster than our molecular because of that shipping time going out of province. So that's kind of where they're going on. The last couple of things I wanted to mention is we have been discussing for Can West next year to do a Strangles laboratory so anyone who might be thinking about coming. This is something we've done with our students and something that you can actually do at your clinic as well. So this is an example of the biosecurity lab, which we do with the students, where we create this barn on map, and they, as was shown today, have their different stickers for the green and red. And thinking about the movement. And then this is not actual chondroids, those are yogurt covered raisins in a cadaver skull, and we can practice doing all of our procedures for testing as well as cleaning, which is a good practice for those who don't do this all the time, but it's becoming more and more common. So Allison, I just threw this in as Allison was talking about it. The disease alerts on the EDCC, I went and put the Strangles in here. And one of the major things that I think is a really big issue, in addition to losing this information on what's happening within our province when they aren't notifiable or reportable, is that we're also losing kind of that ability to say this has to be reported. And so veterinarians, when they have a positive case of Strangles, can either go on to the EDCC or our CAS, and we will cross-post them both directions. And so it is something that a lot of owners are worried about. It makes it easier if we do have them as a notifiable disease, because then they are being notified to the province. But we can do this without having that provincial reporting. So it is really important. And we are able to get those database information coming from the EDCC as well as the CAS, so that we can use that for information going forward to help educate everyone along the way here. So that's all I had.
All right, thank you very much, Ashley. That's very cool, actually, with the live demo. I find it was very useful for actually visualizing something instead of trying to watch a diagram on the page. And I also agree with Doris. I think you've just ruined yogurt, covered everything for everyone on the call. So thanks for that. Our final panelist is last but not least, our collaborator at WeCan, Dr. Barb Wilhelm, to give an update from the lab perspective from WeCan.
Yeah, thanks very much, Mary, and thanks all the other panelists and Dr. Boyle. Wonderful, wonderful presentations. And so Mary and I had kind of agreed we're anticipating, in the interest of time, maybe I'll just share a couple of points. As I said, WeCan started collating some of the historic lab data from the other Western labs, aside from the DSU at UCVM. And so I can share points from a couple of other prairie labs, perhaps very quickly. One has a LIMS, or a lab information management system, dating back to April 2014, and one to 2016. And so at that first one, looking at time trend analysis, I was sort of curious, just try and get a feel for, is there a bad year? Is there a bad year across the prairies? There was definitely in that first lab, dating with the data going back to 2014, which has probably the larger footprint and I think the larger equine population that it serves, actually. Definitely a baseline level of diagnosis every year and every quarter since April of 2014. There have, in fact, been a couple of upticks. There was a major one apparently in the spring of 2015, which personally I don't remember. I too am an equine practitioner, and more recent one in the winter of 2022. So wondering about my question of, well, is there just a bad Strangles time? I guess the prairies I demonstrated is a big place. At the other lab, there was one uptick, which was in 2019. So there, as others have alluded to, you would have these pockets of outbreaks, I guess, for a variety of reasons. I was interested when Allison mentioned the seasonal trend, although that might have been a paper you're referring to. I did do a time series decomp on the lab that had the larger data set. I did see a seasonal trend, actually, with a bigger spike in the spring and a smaller one in the fall. It was noted with the software I was using, but it was a very small magnitude, but still kind of an interesting finding, I thought. Thinking that it might be interesting to look at whether practitioners are currently actually using combined strategy in their diagnostics. So I looked at particularly with the larger lab, they do offer both culture and PCR for the last few years. Anyway, of course, the PCR is newer. Currently, requests for both culture and or at least culture positive and coinciding with PCR, very, very rare in the data set. So in the backhanded way, maybe there's good news. We can do a little communications on those points if there's an advantage in sensitivity. And then finally, looking at the antimicrobial sensitivity. At that one larger lab, we had AST data for their strep equi, well, all their streps dating back to the 2014, and just corroborating what others said. Penicillin, Ceftiofur, both were basically undefeated, if you want to look at it that way. This relatively small data set, because not every isolate was then had antimicrobial susceptibility testing, but they were both. There were no resistant isolates categorized for either penicillin or Ceftiofur. Pretty similar. It was interesting to me, and what UCVM had mentioned, relatively high, particularly in strep equi, even more than strep. So relatively high resistance to aminoglycosides in strep equi, and lower, but still some isolates resistant to amrofloxacin at TMS. But again, penicillin, if you want to use it on the basis of resistance anyway, remains like it looks like a great choice. So that's all. I'll stop there. Thanks very much, Mary.
Okay, thanks very much, Barb, and thank you to all our panelists for the update. So one final reminder for participants, please put your questions in the Q&A section at the bottom of the screen. If you do want to ask your question in person, you can raise your hand, and hopefully I will see it as well. There are quite a few questions, 5 or so right now, and maybe more will come in. I'll start with the questions for the panelists because there's 2 of those, and I think I'll just get them out of the way. So the one question will be for Kathleen. Because it is not immediately notifiable in the Maritimes, is it possible we are largely underrepresenting cases, and are veterinarians Are veterinarians the ones that report cases, or is the lab responsible for that? I'm aware of more outbreaks in Nova Scotia than what were reported.
So if it's reportable, then the lab would notify directly, but since it's not, I don't believe that they have that responsibility or capability to do so, but someone else can correct me if I'm wrong. Also, I think that there is kind of an undercurrent of disease, and that's why it's never gone away. And not everyone is going to test or talk to their veterinarians about it. So I think that it just kind of cycles through. So it doesn't surprise me that there are more cases, but from what I'm aware of, or the laboratory at ABC is aware of, it's been quiet here lately.
Thanks, Kathleen. One thing I will plug in, if you're from the Maritimes, you may notice that Ontario has an animal health network. Owen, Quebec has an animal health network. Réseau, Western Canada has an animal health network. We can, and you may or may not know, but Atlantic Canada just is getting their network started. It's called AtCan. And so hopefully we will be able to get more of those reports coming in through AtCan, which will then filter to CAS. And maybe we will have some improved disease reporting within Atlantic Canada for things like strangles and various other diseases as well. So for our maritime or Atlantic Canadian participants, you should support AtCan as it gets going and gets underway. So keep an eye out for that. Thank you, Kathleen.
Yeah. I think it is important that we do try to approach these things regionally. There is a lot of movement within the maritime horse population as far as racing and showing, buying and selling. So as a region, I think it is important that we try to approach it as cohesively as we can.
The next question is for Dr. Rondeau. Dr. Rondeau, est-ce que tu as dit les numéros de la gorme pour l'année 2022?
What did you say? Le numéro de quoi?
Les numéros de les cas de la gorme pour l'année 2022.
Seven. I don't have for 2020 because I didn't have the results from the labs. I only have these results since 2023.
Okay.
I started working at the MAPAC in February 2022, and with taking the réseau, c'est le, excusez, c'est le
network, yeah.
The network
yeah,
since
yeah.
then, and to get a good relationship with the partners and everybody, and to know people. It takes sometimes, and now it's going very well with the good collaboration with veterinarians and laboratories. I'm very happy about this good relationship.
Yes, me too. Thanks, Martin. So the rest of the questions are for our speaker, Dr. Boyle. You want to bring yourself back. The first question you may have answered because you talked about it later on. The question came in early, but do you have any comment on Strepvax 2 WRT efficacy in North America?
Yeah, I mean, I'll be honest, I actually have used the modified live pinnacle vaccine more, but I do think that, and that's just kind of how I was originally trained. It definitely, I've used it in cases of in pregnant mares, because the pinnacle vaccine is not it hasn't been shown to pass maternal antibodies to the foals. But I mean, the drug company BI will say that it works well. As far as like risks of complications associated with it. I think it probably got a bad rep at one point, and I think that both of them can have risks of purpura. So I think, if you pay attention to the SEM titers, that can help lower your risk associated with that.
Thank you. Next question. Do you recommend scoping a horse that tested positive and only presented with a fever and runny nose, but no other clinical signs such as lymphadenopathy, if that fever lasted 2 weeks or longer?
Yes, I would. I mean, I think that, that's quite a long time to have the fever, and I'm a proponent of scoping a lot of the horses that are affected if you have that capability. I know not every veterinarian has a scope that they can use, or may not want to put their scope in a dirty horse for the reasons that I mentioned before. But as far as cleaning it, but the I would recommend that. Yeah.
Next question. To clarify, what is the best practice to clear a horse from an outbreak? 1 negative GP lavage, or 1 negative GP lavage followed by 2 consecutive negative naropharyngeal washes, or 3 consecutive nasopharyngeal washes?
Yeah, so ideally, I think having the 1 negative guttural pouch lavage, but the timing needs to be right. So it's a negative guttural pouch lavage at the beginning of an outbreak is not necessarily going to be the right time to do that guttural pouch lavage. But when I'm checking for carriers and I'm at the end of the outbreak, I'm comfortable with 1 if I've scoped them as well, because as long as they look clear. If you don't have the capabilities of doing the guttural pouch lavage and the end endoscopy, that paper out of Sweden talked about, Dr. Pringle's paper, most recent paper, looked at saying that the 3 nasopharyngeal washes was good to determine carrier status, and as I mentioned in one of the earlier slides, that sensitivity was as high as 93%. So that's pretty good. So yeah, I find that I have trouble getting people to do the 3. So I actually find it easier to actually convince them to do 1 scope than to do 3 nasopharyngeal lavages, because they're having to wait. They just want the whole thing over.
Understandable. Next question. Is accelerated hydrogen peroxide preferable over glutarate for disinfecting the scope, equipment, and other instruments?
I'm actually not familiar. Is the glutarate the same as the OPA? I'm thinking it's different. So I actually am not. The accelerated hydrogen peroxide was found to be better than the OPA. To be honest, I've been using OPA. The thing that they found or they commented in that paper is that a lot of the endoscopes actually are not approved to use the accelerated hydrogen peroxide, that it may damage the scope. So they talked about how you really should contact the scope company to see whether it's safe to actually use the accelerated hydrogen peroxide on the scope you're using, so you don't damage your scope.
Next question, we'll just do a couple more and then we'll call it, because we're getting at the end of time. How many weeks apart do you spread out the 3 nasopharyngeal washes?
So ideally, the original consensus statement talked about doing that at weekly. Again, I think that's where it can be hard to get people to do it because they don't want to have a 3-week process. So I think it should be probably at least probably at least 5 days in between, because you're looking for that intermittent shedding. As Dr. Moore stated, that some horses will intermittently shed, and then a week later they're negative on the good old pouch lavage. But that's the original consensus, they talked about a week apart.
Okay. And I do have one question, just because I'm a big fan of antibiotics, my specialty. And you talked about antibiotic flushing of the guttural pouch. Which antibiotic do you use for that? Because we know penicillin is very effective against Streptococcus, obviously, but it struggles a lot of time with the contact killing of bacteria. So are you using penicillin in those flushes, or are you prioritizing a different antibiotic for the local flush?
Yeah, I am using penicillin. I actually use very often. I'll actually use a quartermaster dry cow treatment off label, and dilute it into because that will actually, I can have that on my truck and not have to have it compounded from a specialty pharmacy, but and it's a lot cheaper. But I know what you're talking about, because I've actually had, that's where a lot of times will recommend systemic antibiotics for those horses at the same time, because I have had horses that have failed their treatment when I've just used local treatment. Yeah.
Yeah, that's cool. See, cow mastitis tubes are useful for everything, I think. Yeah. All right. I don't see any more questions. So if somebody does think of a last minute question, please feel free to reach out to myself or Doris, and we will pass that on to Dr. Boyle or our panelists, to get you the answers, the information that you need. I would encourage everyone again to check out the networks that were mentioned. So Owen, Razo, WeCan, AtCan, EDCC. They're all useful information sharing and gathering networks that we can all participate in and keep up to date on things that are happening. And so with that, I would like to say a big thank you to Dr. Boyle for taking the time out of her busy schedule to give this presentation. Strangles is definitely a relevant topic. You know, show season's coming up, it's warming up, so we probably all need to be aware and diligent. And a big thank you to the panelists as well for sharing their information on a regional level, and for participating. And finally, a big thank you to all of the participants. I know everybody's really busy, you know, trying to be a veterinarian, and that gets pretty busy as well. And I know this is, at least in Atlantic Canada and in Ontario now, it's starting to get late and eating into our evenings. So I do want to thank everyone for their participation, speakers and attendees. One final reminder that it was race approved, so you should be getting your CE certificates after the conference. You know, maybe give it a week or so, and then if you still haven't received it, feel free to reach out to me and Doris as well. And so with that, again, thank you very much. I hope everyone enjoys their evening, and please stay tuned and stay up to date on, you know, future CAS webinars, future CAS projects, and information resources that we will continue to share as time goes on. So thank you again, everyone, and good night or good evening.
Thank you.